Apurva, are you there?
Yes, sir.
Okay, I think Dr. Ajay was supposed to be there. He's not there. All right, no issues. Once again, welcoming everybody. Thanks for tuning in. And case contributors, thanks for sending in your cases. This should be a relatively short meeting. I think we have around 5 or 6 cases. Um, let's see if Dr. Ajay is the first case. If not, we can start with the rainbow cases. Yeah, without further ado, we'll start off with our cases. That was Dr. Ajay's case. But yeah, Apurva, over to you.
So this girl is a 12-year-old female. She first came to us in 2022. That time she had bilateral optic neuritis, which progressed over 1 week, and there was no symptomatic complaints in this child. So here she was managed outside with methylprednisolone pulse therapy for 5 days, and then usual tapering of oral steroids. And she was on 1 year of oral steroids, and there was improvement in symptoms within 3 months. And gradually after 1 week, everything was tapered and stopped. So, in the first episode, she underwent an MRI scan and a CSF analysis with MOG, NMO antibody, and CSF oligoclonal band. In the second, so last 1 year after stopping, she was completely asymptomatic. She had gained her vision to completely normal. Now, again in January 2025, she came with an isolated unilateral right side optic neuritis. Again, had the similar course of management with methylprednisolone and pulse therapy. After the scans, we'll discuss the labs.
Okay. All right. So this is the first scan in 2022. Flare and T2 axials out there. And you can appreciate there is some focal abnormalities along the cingulate cortex on the left. You can appreciate that over here on the first panel. You have some subcortical deep white matter abnormality on the right side, right parietal or peritonic region. More confluent abnormalities in the posterior hemispheric white matter, almost passing the hemispheres on both sides, involving the posterior aspects of the corpus callosum, going up to the subcortical regions from the periventricular boundaries. As you can see, they are more confluent in nature, coming down into the temporal and occipital lobes. In the posterior fossa, I could not appreciate any signal changes. And on the T2 weighted sequences, additionally, you can appreciate the prominent sulcal spaces, signifying there is some reduction in the volume of the supra and in the infratentorial brain parenchyma. So confluent abnormalities in the temporal, occipital, and parietal lobes, and some focal abnormalities in the right peritonic parietal region and also in the left paraphalcean region out there. Post-contrast diffusion, there were no abnormalities on the SPINacademics sequences. Post-contrast, none of the lesions demonstrated any enhancement. Could not appreciate any significant enhancement on the optic nerves as well.
So she was first isolated clinical demyelinating event where NMO-MOG was done, which was negative, and she also underwent CSF oligoclonal bands, which were negative in the 2022 scan, and no other further immunomodulation was given as the child had symptomatically improved, and we didn't have any antibody per se positive, so it was a seronegative demyelinating event.
Okay. So 2025, anything particular after 3 years in terms of presentation?
Again, she had a right-sided optic neuritis. Again, no systemic complaints. Unilateral right side blurring of it.
Okay. So this is the most recent scan. I think done a couple of months back in February. And you can appreciate there is some progression in terms of the lesions, especially in the subcortical paraphalcean abnormalities out here. They're more confluent in nature. The focal abnormality is still present, which was seen on the previous scan. Again, confluent changes demonstrated in the posterior hemispheric white matter involving the corpus callosum. Possibly some faint hyperintensities in the middle cerebellar peduncle and the cerebellar cortex in the inferior aspects of there. Thinning of the corpus callosum, again, you can appreciate the splenium has some focal abnormality. So in terms of imaging, there was some progression, especially in the paraphalcean regions, and maybe some posterior fossa changes. As the child had optic neuritis or suspicion of optic neuritis with vision complaints, you can appreciate there is restricted diffusion, especially more on the right optic nerve. And on the post-contrast sequences, you can appreciate that there is enhancement of the right optic nerve. The parenchymal abnormalities did not demonstrate any changes in terms of contrast enhancement. And there again, no changes on the diffusion sequences or the SPINacademics sequences.
So this time again, repeat NMO Morgan CSF oligoclonal bands with CSF analysis were done, all of which was positive. There was no raised proteins, and ESR was 44. So here, considering this as a second episode, the child was given again methylpred pulse therapy, oral steroids, and then started on rituximab. So the question specifically was, is this an episode of a multiple sclerosis, or do we need to treat this as an MS? Because the second episode was a unilateral involvement of the optic nerve with confluent involvement of the brain.
OCB is twice negative, Vijay. The question is because the immunomodulation and the counseling becomes completely different. So we don't have both the times oligoclonal bands are negative. So do we still go ahead with this one? Managing as MS because there are confluent white matter changes which are accumulating.
This is the first time I came a little late. I'm sorry.
Here's the first MRI, doctor.
This was basically just
There's some posterior dominant.
come with what? With what is the story? It's
Uh,
okay.
yeah.
Okay.
Apurva, you can quickly summarize the story to sir.
Two
I
episodes.
got it. Yeah. So basically, bilateral optic neuritis, second one was unilateral optic neuritis.
Yeah, and some progression in terms of the parenchymal changes.
But you had contrast enhancement in the first, you didn't have it, right?
No, not on the first, not on the second. On the second, the optic nerves, the right optic nerve demonstrated enhancement.
It doesn't fulfill the criteria, does it? It is basically you have
So new optic neuritis and some progression lesions. I think yeah.
but no enhancement and no OCB positive, right?
Yeah.
OCB twice negative, Rajesh.
Have you done? Can you do the EB virus serology and see if it's positive? If it's negative, it rules out MS.
Okay, sure. We will do that. Definitely.
I mean, it's not rules out, but it makes it less likely.
Less likely. Yeah, sure. Okay, thank you. I think we'll move on to the next.
Yeah.
Thank you. Thank you, Rajesh.
Yeah, Razi, you there?
Just one question, Nihaal, is it possible GFAT?
It didn't enhance. That was slightly.
Yeah, then point against.
Yeah. Yeah, Razi.
So I answer. This is a 4.5-year-old boy presented with history of moderate rate intermittent fever since 10 days, dull activity and excessive sleepiness, and decreased acceptance of feed from 6 days. So he was admitted in PICU in view of encephalopathy. Child was intubated, put on mechanical ventilation. Child had very high requirement of inotropes in view of shock, cool peripheries, hypotension. And eventually, when the child was evaluated, child had liver failure, severe coagulopathy, required CRRT for high ammonia levels, more than 600, and 2 cycles of Plex were given. And apart from that, birth history wise, non-consanguineous second in birth order, full term LSCS, nothing very significant. On examination, so this child was admitted under PICU, and then we were called around day 8, day 9 to assess for the encephalopathy part. So on examination, child had some fever spikes, tachycardia, blood pressure was maintained on fentanyl and dexmed sedations. Child was E2, VT, M5, and brainstem reflexes were present, and child had localization to pain. They wanted to rule out. So the discussion was to find if it is related to hyperammonemia related changes, because despite the ammonia getting better and the liver parameters, coagulation profile all improving, platelets improving, the encephalopathy was still persistent. So what was the hit in the brain was the question. So that time we had advised for an MRI brain.
This child had some positive viral infection. Is that right? Yeah.
Yes,
Yeah.
sir.
Influenza was positive.
Influenza is
Oh.
positive.
Okay. So the scan was done on 5th of May. So these are the labs done before the MRI. Yeah, Anisha, viral markers, I think influenza was positive. Yeah.
Yeah, other protein hepatitis viral markers were negative.
Got it. Yeah, and the only finding here in the ultrasound, we had mild hepatomegaly with some gallbladder volume and minimal ascites. So changes were likely for acute hepatitis, is what they inferred. And after that, I think the child had an MRI. So MRI again, T2 axials and flare axials. You can appreciate there is edematous changes involving the cortex and also some degree of the white matter structures. Subcortical deep white matter, also the deep brain nucleus structures have these hyperintense changes. Uniformly in the supratemporal brain parenchyma, maybe some degree also in the brainstem and the dentate nuclei, with reduction in the volume of the cerebellum, more often in the vermis. And flare again demonstrate the similar changes what we have seen on the T2s. You can appreciate there's gray and white matter involvement. Some hazy abnormalities in the white matter and the cortex and the deep brain nuclear structures demonstrate these changes on flare sequences. Cerebellum also has edematous changes, as you can appreciate over here. The established sequences demonstrated extensive areas of microhemorrhagic foci, predominantly in the peripheral region, but also if you see in the central areas involving the corpus callosum, and also some degree of the basal ganglia, superior basal ganglia demonstrated microhemorrhagic changes. Also in the cerebellum on the left side had this microhemorrhagic punctate foci. Diffusion sequences did not demonstrate any cytotoxic edema. Yeah, so all of the changes which are seen on the T2 and flare demonstrated facilitated diffusion. Sorry. Yeah, so the question here was, I think as Apurva has asked, are these changes related to acute hyperammonemic encephalopathy? Is that right, Razi or Apurva? And are these
Yeah, in absence of restricted diffusion, what are the
differentials
for these kind of changes for the debate?
Platelets or abnormality? Hematologically, Razi?
Yes, sir. Like cytopenias were there.
Okay.
Yeah, and elevated ferritin, LDH, and D dimers and fibrinogen were elevated. And with ammonia, like initial presentation, SGOT and SGPT around 5,000 and 3,000 values were there. Gradually, after CRRT and PLEX, it improved over 10 days' time. Yeah, the renal parameters, multi-organ dysfunction basically with encephalopathy. Dengue, mycoplasma were negative. Influenza A came out to be positive, and hepatitis panel was also negative. Blood cultures were negative so far. Currently, child has been extubated and still mild encephalopathic. Eye opening is there, and minimal flexion response to pain is there. Able to maintain saturation with minimal oxygen support.
Does not fit HLH, no, Razi, or?
Ferritins were initially 17,000, sir. Over a period of time, 1 week, it has reduced.
So I think the classical features of hyperammonemic, you have more cortical involvement, these edematous changes which are not seen in diffusion. And hemorrhagic changes again were slightly atypical, as Anisha also pointed out.
Other question we had with this scan was this because the child had already received 2 cycles of Plex and the child was improving. So was this an early insult and now there was pseudo normalization because there was no restricted diffusion? Like, do we need to treat, though ICU team had given anakinra, so is there a need to treat or wait for it to get better?
This is 10 days into illness, no?
Yes, sir.
7 days. No, I would still think there would be some diffusion changes because it's completely normal. And again, some white matter involvement. I mean, they're usually corticals, predominantly cortical changes in hyperammonemia.
Line number 60, 2027 to Delhi will soon be ready for boarding. Passengers requiring special assistance passengers traveling with the tanks may come forward. All other passengers may be there. Boarding pass is ready for sequential boarding. Thank you.
The T1 did not show any changes, right?
No, Dr. Not put it up, but yeah, it hasn't shown any. No laminar necrosis or anything there. Pneumococcus, Dr. Vijay mentions possibility.
So, influenza associated itis, I mean, encephalopathy. Besides the neck, you also get these cerebral edema with is the brain little tight?
Actually, it's actually atrophic. Let's see. Yeah, there's some atrophy. I mean, sulcal spaces are pretty evident. So.
Hi everyone. Hi Nihaal, how are you?
Hi, Bulent. Hi.
Hi. Are there any risk factors for rickettsial infections? Rickettsial, sometimes they can present with these tiny microhemorrhages, predominantly involving white matter and also splenium of corpus callosum. There are huge differential lists. One of them is, like rickettsial infections, like high altitude cerebral edema, fat embolism, etc., etc. But with this clinical information, rickettsial infection, I think it's
Wheel Felix and
possible.
scrub typhus was negative in this case.
So I think the first question what they wanted to know was, are these the primary hyperammonemic changes, or is it secondary to an infection trigger causing these very matter changes in microhemorrhagic flow? I think those are the two main questions.
For me, we many times see this, picture, especially in systemic issues, like, the patient, if the patient has, respiratory failure, in ECMO, post-intubation, systemic issues. I think some sort of, like vasculopathy is going on in these patients, and we see some cerebral edema and also microhemorrhages, but I don't see classical, like, of course, hyperammonemia, hyperammonemia can cause cerebral edema, but, it's not classic, I think.
Thank you.
Thank you.
So I think we're more towards an infection which has triggered it, causing these changes, and the
I just wanted to ask, any peripheral smear examination done? Why the low platelets, the rapidly fluctuating WBC count from that point, since CSF and bone marrow are not feasible?
Yes, sir. Peripheral smear was showing normocytic microcomic anemia with occasional cystocytes were there. And occasional megaplatelets also been documented in peripheral smear, one of the peripheral smear.
No toxic granules.
No toxic granules, sir. Shift towards left in neutrophils. Sometimes like WBC agglutination was also seen.
Okay, so we'll at least agree that changes are not classic for hyperammonemia, the acute hyperammonemia, and possibly secondary to an infection-related sequelae. There are no other comments. I'll move on to the next case. Yeah, Dr. Nani, sorry. Okay. Payal, if you're there.
Hi, yes, sir, I'm there. So this is the 2-year-old boy came with the complaint of side to side, like no-like movement of the head from the last 2 months. Birth history, these movements were like at the frequency of 1 per second, sort of. Sometimes frequency was reducing or sometimes increasing, but it was not going on the distractions. It was absolutely normal at the time of sleep. Other than that, no other symptoms were there. Birth history was uneventful. Development was appropriate in all domains. On examination point of view, head circumference was also appropriate. No neck stiffness, no neurocutaneous marker. Tone, although tone was little bit of a lower side in the bilateral lower limb, reflexes were elicitable. No ataxia, no fall during walking. All cranial nerve was intact, and there was no nystagmus, no tremor, no speech. He was able to say appropriate for the age. So I would like to show the video of the child. This was the video. Sudden onset only from last 2 months.
Is this like a titubation? Sorry.
No, side to side movement, side
Okay,
to side.
okay.
So that's it. But just because I wanted to, as a spasm mutants or this stereotype is the diagnosis of exclusion, to just to rule out the SOL, we have proceeded with the neuroimaging.
Okay, the scan was done I think a couple of days back. The main subtle changes are in the posterior fossa. Supratemporal normal, no malformations, no signal changes, no focal abnormalities. If you look at the brainstem, particularly the dorsal aspect of the brainstem, if you see as dorsal pons is slightly hyperintense, coming down the superior cerebral peduncles, also on the right side is more hyperintense and slightly more thickened in comparison to the left. Some changes in the vermis out here at the anterior vermis. Yeah, so these were the main findings: dorsal brainstem, superior cerebral peduncles, middle cerebral peduncle on the right side particularly, and some peridentate changes with a thickened superior cerebral peduncle on the right side. You can appreciate the thickened cerebral peduncle on the SAT sequences. Though these are not thin cuts, but here you can see that it is slightly thickened. Mild hypoplasia of the corpus callosum. And on the diffusion sequences, these changes, some areas demonstrated punctate areas of low signals on the ADC, some restricted diffusion, and rest of them had facilitated diffusion. So yeah, predominant changes in the dorsal brainstem, also involving the peduncles and the vermis. No other sequences were done. There's no hemorrhage, no necrosis. The contrast wasn't done. It's planned to be done tomorrow. So yeah, these are the main findings. Yeah. So Payal, you can just ask what your main concerns.
Okay, so investigation wise, only a slightly raised total leukocyte count is there with lymphocytic predominance. Apart from that, nothing is there. So this changes. I wanted to ask, like, how aggressive do we need to go, because CSF has not been done. Contrast is planned for tomorrow. Other than that, child doesn't have anything. No nystagmus, no ataxia, no cranial now, no neurocutaneous markers.
Tested for antibodies. Question from Shreyas. I don't think so. I think child has just come to us. Right?
No, planned for contrast even after having these images, planned for contrast tomorrow. Contrast imaging.
Contrast may not be that helpful at this point, but let's see. Any cranial note? No cranial note.
No, nothing. I don't have the walking video, but he was walking fine. No ataxia.
It's the question. You're sure about the restriction, right?
Yes, Dr. Rani, sure. You see this?
Because one thing I was thinking about was that some sort of martyrs changes of NF4.
Yeah, that's what I also asked her, but Payal says that as of now there are no new cutaneous markers. Is that
Nothing
right,
is
Payal?
there, sir. Yes, sir. Yes, sir. Nothing is there.
But they
And
do
there
look
was
like
no
those.
nystagmus, right?
No nystagmus, sir.
Then the question is, bobblehead doll syndrome is usually a kind of more continuous. This is like an intermittently acid, right?
No, sir. He is having continuous, only disappearing during the sleep.
No, but he intermittently does it on the awake.
Pardon, sir. I'm not.
Is it continuous or is it an intermittent kind of movement?
Continuous frequency is varying. Sometimes it is little bit fast. Sometimes it is slower, but it is continuous.
Development wise, okay. Payal?
What, sir?
Development wise. Developmental issues? No development issues.
No development issues. Development is fine.
Okay, Dr. Vijay raises question of mitochondrial.
Sir, only a basic blood test has been done in which the TLC is little bit higher side. It is like 15,000. That's it. Other than that, no handles. Investigation wise.
Okay, the question here is, do we need to do any other sequences? Is the first question.
And
Spectroscopy,
do we like
contrast.
CSF is necessary after seeing this imaging finding? Do we need to like how aggressive can we go like this? Because child doesn't have any problem apart from this movement. He's running, playing, everything.
She either says follow up after 6 months.
Oh, yes, sir. Oh.
How do you treat the movement disorder? Is it self-limiting or?
This is the final voting announcement.
If it's not affecting the time, they can wait.
60-2027 today. All messages.
Dr. Vijay, yes, I thought diffusion maybe will complete the study with contrast and spectroscopy. That is what is planned tomorrow. I think the child is in Jabalpur. No tractography. So maybe Payal, we can just complete the study once, see if there are any significant changes. If not, then we can have a follow-up.
Okay.
3 to 6 months.
Yes, sir. Yes, sir. Sure, sir. Thank you so much, sir.
Okay. No spinal cord symptoms, no?
No, nothing.
Okay. All right. So we'll have a look at the scan tomorrow and maybe put it up for next week. Next time.
Sure, sir. Thank you. Thank you so much.
Yeah. All right. Basit, what do you?
Yes, sir. So our case is 7.5 years old male child, non-consanguineous. So illness started in 2021. When he had this subacute onset behavioral issues in the form of anger, outbursts, inappropriate behavior, and these things just last for around a month or so. And during the same period, he was complaining of headaches, but they were not severe enough. They were not noticed initially. So mild headaches. This thing lasts for around a month or so. So 1 month after, he had this sudden onset of weakness in the right leg. So it was a sudden onset. He was not able to lift the leg and he needed support while standing as well as walking. So after that, they got him admitted, and in the same period, 2 weeks after this, had a one big seizure of focal motor status basically, and he got admitted, and then he was encephalopathic for around 1 week that time. So during this admission only, when he had a seizure, he was this MRI was that was suggestive of hydrocephalus with some spinal lesions, and for that hydrocephalus shunt was placed, and this spinal lesion was biopsied. He was admitted for some time, and within 2-3 weeks, his condition improved, and he was discharged. Uh, so can we see the initial this MRI?
Yeah.
There are two in the first one and the interval.
Right. So I have 3 MRIs, 2 brain
Yes,
and spine, 1 spine.
yes.
So this is the initial presentation T2 in 2021.
Yes.
There is hydrocephalus with periventricular edema as demonstrated on the FLAIR sequences. But if you look closely at the cerebellum, you can see that there is some hyperintensities in the bilateral cerebral hemisphere. There's some they restrict on and they restrict on the suppress on the FLAIR sequences. So possibly there is some prominence of the subpiral spaces out there, especially in the cerebellum. But otherwise, there is hydrocephalus with edema, no focal lesions in the, cannot appreciate focal lesions in the parenchyma. Papilledema is there. So raised ICP features. Yeah, on these sequences, yeah, that's all I can.
How?
On the SAD sequences, in terms of the abstraction, not ideal, but yeah. So again, there is also apparent enlargement of the fourth ventricle going up to the cisterna magnum. So it looks like a communicating hydrocephalus with these cerebellar abnormalities or cystic changes in the cerebellum. Spinal cord, as Basit mentioned, there was a abnormality in the spinal cord, especially in the thoracic region. You can appreciate the cystic changes as again in the thoracic spine with enhancement. Some areas demonstrate nodular enhancement, some have peripheral enhancement, and there's also an enhancement of the cortical nerve roots. So this was the first scan. Child was biopsied. The spinal lesion was biopsied. I think at this point, if they had asked for possible, I would think of DLGNT as one of the possibilities. But so on biopsy, Basit, if you just want to summarize what was biopsy.
So they had suspected this basically VHL, and they had this biopsy was given to be some vascular tumor, not sure. Then they had stained it for hemangioblastoma also, but that came to be negative. His CSF examination was done, that was showing high protein but no cells. Protein was high initially around 120, and then it had decreased. Repeat CSF was done, that the CSF has normalized. So based on this biopsy, they had treated as kind of some vascular malformation, coiry hemangioblastoma, and they had done genetics for VHL, and that was negative, and they had stained this for hemangioblastoma, and it had come to be negative. So after that the child was discharged. He was doing well, he had improved, he had started walking again, his weakness had improved, he had slight residual weakness on in the right limb, but he had improved. Then after that, in around 3 years after, 2024, he had this epilepsy. He started having epilepsy. This was a drug-resistant epilepsy with frequency around 2 to 3 episodes per week in the form of temporal lobe, look like this non-dominant temporal lobe seizures. So basically, currently, he came to us last week with complaints of basically epilepsy only, and seizure frequency currently is seizure free from last 1 month, but his previous frequency was around 2 to 3 episodes per week. So this was a 2024 MRI when he had started having epilepsy.
Right. So diffuse cystic changes, predominantly subpiral cystic changes, supratendular and infratendularly more in the cerebellum. The hydrocephalus has reduced, but as you can see, there are multiple cystic foci, parenchymal and extraparenchymal, extraaxial regions. Contrast in the brain, there is some meningeal enhancement, especially along the basal cisterns. Some cranial nerve enhancement along the facial nerves and eighth cranial nerve. Spine, you have again progressive changes in the spinal cord, diffuse involvement of the spinal cord with the cystic abnormalities. Post contrast, again, you have diffuse leptomeningeal enhancement and some nodular enhancement of the spinal cord lesions. Yeah, at this point, I think we're thinking of DLGNT, and the majority of you in the chat also have mentioned that as a possibility. And this was.
Okay, finish.
Yeah, I'm sorry. And this was the scan. I think the recent scan, only spine was done, and again, in the spine you have similar changes. Brain wasn't done, but you can appreciate the brain changes also seen in the posterior fossa. Yeah, Dr. Rani. I think the biopsy was.
Problem was that biopsy was not fitting with this MRI diagnosis, and the biopsy had been sent to higher centers and all sorts of things, and there was no question that there was no mention at least of a clear neural tumor. So this diffuse leptomeningeal gliomerular tumor was not ready. And the funny thing was that this vascular thing, which was now. Then afterwards, do you have any other thoughts? Because we had some thoughts, but
No,
I just want to put it up for you.
no, I think I'm pretty going with the DLGNT only.
Anybody else have any ideas?
So we had a case, child with the same. The biopsy turned out to be, we diagnosed diffuse leptomeningeal glioneuronal tumor. The biopsy turned out to be diffuse midline glioma. So again, there is a discrepancy from the histopathology versus. So radiologically, it's almost sure that this is diffuse leptomeningeal glioneuronal tumor.
Well, no. Well, there's this condition called diffuse leptomeningeal hemangioblastomatosis, which can sometimes follow a surgery for a hemangioblastoma or something of that sort, and you may actually get dissemination of the tumor along the leptomeningeal axis. That was a question I had. That should we go into the biopsy again or what? Because one in diffuse leptomeningeal hemangioblastomatosis is not a very worse prognosis than the leptomeningeal gliomerular tumor. And so that was the question. We've asked for the block from.
So the previous biopsy was from the spinal cord or from the
spinal cord. So there was this lesion in the first MRI which was done. There was no Foucault-Robin spaces or nodular enhancement anywhere. But after the surgery, it sometimes happens if it is a hemangioblastoma, you spill the cells in the CSF, they can actually disseminate over time. So I don't know, but of course the problem is.
Actually, on the first scan, I mean, in the cerebellum, you can appreciate these.
Yeah, they were there also.
They were there. Yeah, they were there that time. So I think you still think of DLGNT as the prime possibility.
But even in the first scan, the leptomeninges is showing enhancement in spine. Some thickening is there, leptomeningeal.
Yeah, it is.
Leptomeningeal hemangioblastomatosis can occur de novo or can occur with after surgery. But the whole problem is that usually you would get some diagnosis from the biopsy, which over here we have not really got. That's why the question is whether it's this or that.
Yeah. So we all agree, Dr. Orani, I think you still
no, we also have the same thing. I think the MRI was the main reason for showing this was the MRI was completely different from what the actual biopsy turned out to be. That is the only thing.
I got it.
Any consensus on the grade of these tumors? Because some of these tumors, if it is thinking that it is diffuse leptomeningeal glioneuronal tumor, even now it is not very clear. Some will have a very indolent course, some will be rapidly progressive, some enhance, some don't enhance. So it is still a very group.
Some are diffuse, some have more focal, not pretty focal lesions, especially in the cord. Some have oligodendroglial features also, if I'm not mistaken.
Yes. So it is a very
some discrepancies there.
Diverse group, I think.
It's a very, very variable kind of prognosis. I agree with that. Okay.
Okay. Thanks. Yeah, Vasit, I think this was a follow-up case with
yes, this is a follow-up case we showed last time. This 7-year-old boy with history of basically posterior circulation strokes. He had initially left-sided of this gastroenteritis, then he had left-sided stroke. Then within 10 days or so, he had one more stroke in right cerebral hemisphere. So basically that time we decided, we had seen his both initially left vertebral artery was involved, and then it had recolonized and right was involved. So we initially had thought of some vasculitis or this possibility of a rotational, this Bauhunter syndrome. So we had gone ahead with this. We have now gone ahead with a DSA. So basically, we want to discuss that now. So left was already showing, right had improved, but left was personally showing some narrowing. And we have not done a DSA with that rotation with this provocation also. So basically, we want to discuss that now.
Yeah, this was the initial presentation.
No, the initial presentation was a left cerebellar stroke.
Yeah, initial was a
Yeah.
left cerebellar stroke.
Yeah, so
and
this is the
then it
initial
was
Later
a
was a right cerebellar stroke.
right, but right had completely improved. Left was still showing some persistent narrowing on the in the left vertebral artery.
Yeah. So initially left, as Basu mentioned, left hemispheric stroke with left vertebral abnormality. I think 20 days later, another scan was done, and you can see there was some focal abnormality on the contralateral hemisphere. This hemosiderin foci, as what you had seen in previous also, was now more prominent. I did not put up the SW sequences on the initial scan. And this is the follow-up imaging. The left was abnormal, and the right also, I think, at some degree.
When you move rotate in the MRI, the head to the left and right, it's clearly the reduction of the size on the left side.
Yeah.
When the head was turned to the right.
This is what I think we discussed here now, and we have now, I think this is our neutral position. And these are on the sideways rotation. So the neck is rotated to the side on the right, and you can see paucity of flow. Let's see again. And on the other side, when the neck is rotated, similarly. Yeah. So I think Basit, what the main question I want to ask?
The main question was, I just wanted to show the follow-up, and the question is, we'll go with the C1, C2 fusion probably, but I think besides the CT scan was done, which is absolutely normal. You have the picture.
Yeah, I have this. I didn't see it, but yeah, I just put up a video. I think it looked normal.
Yeah.
I have a question. Normally, also, if you turn that to one side, no, vertebral artery can show reduction in flow. So how will we be sure that it is Bohunter?
I'm not sure that would happen. The normal movement of the head, your vertebral artery would be cut off like this. I don't know.
Normally, it reduces in caliber, but I don't think in the DS there's complete cessation of flow. Anish, if you want to add anything.
Anish, any idea?
Sir, and I think with the combination of a stroke with this posterior circulation stroke with this loss of flow, I think that will kind of put it
sometimes
definitely as Bohan.
I think Dr. Vijay asked the question. Sometimes these come with ischemic attacks, but without parenchymal changes.
No. Why I ask this because whether it is a one-time dissection which has produced this, or is it a recurrent Bohunter? That is the question.
Yeah, I think we had a couple of cases with normal parenchyma, no stroke, but when the child turned his head, it did show reduction in the caliber. But then again, we did a CT for the child, and the CT there was a definite vertebral bony abnormality, and the child again went on to get a DSA, and that all of them corroborated. So maybe if all of them are there positively, then we can consider it.
Actually, in routine cerebral DSA, unless we are suspecting Bohunter, we don't do head rotation maneuvers. So
that's exactly my question. How many normal cases reduction can come?
We
Whether
do
we
not
are
do it.
overdiagnosing.
Yes, sir. So that we have definitely seen more of these days than we did 10 years back, sir, when I was training.
I mean, what I'm saying is, so what you're saying is that suppose you have a TIA, which is you get dizzy or something of that sort, and your vertebral artery cuts off like this, you would consider that to be a normal thing? Or, I mean, it's very difficult to solve this problem otherwise. There's many of these patients, when Bohunter is usually adult disease. Whenever many of them turn their heads, they get symptoms. And the symptoms are correlated with this absence of flow. So I don't see, is it normal to have complete absence of flow with turning of the head? not really
No,
understood that.
that's what I say.
Yeah.
So because we generally in doing cerebral DSS, we do not do head rotation maneuvers. So in a person whom we are not suspecting, like if you're doing a cerebral angiogram for an aneurysm or for any other cause of stroke, we do not do head rotation maneuvers till we are suspecting or working up actively for a bow hunter. So we do not know how much the flow is actually compressed or what the variability of flow is with head rotation in normal vertebral arteries. But I think in the background of literature and with the stroke, I think so we should go ahead with possibility of this. Of course, in adults, osteophytes and such things and bony abnormalities have been described, but that is not the case in this child, causing the compression and the narrowing. The Vijay sir's question is whether there is this thing which has caused a one-time dissection thrombus, which has caused the stroke, and now the artery is normal.
Past, we used to do this Adson's test for the subclavian, to get, and that turned out
So
to
that
be,
is for
for the
cervical
subclavian.
rib, cervical rib,
Yeah,
yes,
no,
sir.
but
Thoracic,
because
thoracic complete.
they found that there was a lot of false positives in that. So maybe Bijay's question is relevant. I mean, I don't know.
So
Once it is dissected, it is only partially recanalized. So little bit of turning can actually cut off the artery. That's what my worry is.
Over here, the problem was on the other side also, it was cutting off. Of course, in this case, it may be different, but suppose you have only one-sided, then your question is valid. I don't know how to.
But the only thing is in the neutral position angiograms, the artery caliber, lumen, outline looks very normal. There's no evidence of any irregularity, bleeding, or suggestion of any dissection. If you see the first image, if you can just play that.
But probably you can look at that SW if it is there, whether any luminal clot was there or not. The first image.
No, the first scan had hematoma. So this is a non-contrast T1.
So the other thing is, anytime an artery gets mechanically compressed, the cause of a stroke would be one of two: either direct compression causing a hemodynamic stroke, or intimal injury causing a thrombus causing. So in both cases, the mechanism might be different, but that actual mechanical pinching would be the cause of the stroke, whether it is hemodynamic or a thromboembolic.
But I think either way that fusion may help, because that is a site of vulnerability.
Yes,
if you reduce the
Yes,
mobility in that site, I think may help.
Yes, sir.
Okay.
And I'll start doing in my next few angios. I'll start doing vertebral artery head maneuvers just to see.
I have seen reduction in vertebral artery previously. If you turn, complete occlusion will not come, but reduction will come.
But not this time. This is very scary.
Yeah.
Okay. Anything else?
Yeah, I think that should be our last case. So
thank you.
That was a short session. Thank you very much, everyone.
Thank you.
Thanks for your inputs.
Thank you very much.
And thanks for your cases. We'll see you in 2 weeks' time.
See you, Nihaal. Have a great day.
Bye.
Bye.